Thank you, Leanne. Finally, I'd like to welcome Dr. Elsie Taveras, who will be discussing the state of the science on modifiable factors associated with sleep, activity, and sedentary behavior, as well as disparities of the presence of risk factors seen in racial and ethnic groups. Dr. Taveras is Chief of the Division of General Academic Pediatrics and Director of Pediatric Population Health Management at Massachusetts General Hospital. She's also an Associate Professor of Population Medicine at Harvard Medical School. Her main focus of research is on understanding the determinants of obesity in women and children and developing interventions across the life course to prevent obesity, especially in underserved populations.
I want to thank the committee for inviting me to present. It's always hard to follow such an amazing group of co-panelists. I will say that thankfully I'm not going to talk about infant feeding, in which case I would have really big shoes to fill with our panelists this morning. I'm going to talk a little bit in this presentation about other modifiable risk factors for overweight and obesity in infancy and early childhood, and focus mostly on sleep, physical activity, and sedentary behavior, and end with a few slides that will hopefully follow us into the start of the panel discussion, really summarizing what you've heard this morning around risk factors in this early life period. But specifically talk about what we know of socioeconomic, racial, and ethnic disparities in the development of obesity. And that hopefully will also later lead to the discussion about what works, and particularly what works for early life disparities reduction. So we'll start with sleep. I love this quote by Ralph Waldo Emerson: "There was never a child so lovely, but his mother was glad to get him to sleep." I'll tell you how my own research began in a little bit, but in this area of sleep and obesity, but start by describing a little bit about what we know of trends in sleep duration. There's really good data to show that the rising prevalence of childhood obesity that we saw Dr. Ogden present earlier this morning has been paralleled by secular trends of shorter sleep durations in children, and a really nicely done meta-analysis of almost 700,000 children in 2012 from 20 countries going back over 100 years found that on average, children today sleep about 20 to 25 minutes less each day than their parents did when they were their age. And we see very similar secular trends in insufficient sleep, or the perception of insufficient sleep among adults. And the other interesting trend is that across childhood, those 20 to 25 minutes less of sleep that we're seeing is also a parallel change, is that is due largely in part to later and later bedtimes, as some of us who are on call and leave the hospital sometimes at 10 o'clock at night can attest to. There are children who are up way too late at night. If you look again at some of the secular trends and patterns in those children, like that child that I ran into at CVS the other day, what defines, or what are some characteristics of those children who are sleeping too little, or sleeping in that kind of lower quartile of what is recommended for their age? It looks like among infants and toddlers, children who are in that lowest quartile of sleep are more likely to be put to bed asleep versus drowsy or awake, which goes to the point that Leanne made earlier. There might be some teaching of these children to not self-regulate their own sleep, or possibly rely on some external association to fall asleep. Children, older children, in that lower quartile of sleep are more likely to share a room or bed, are more likely to drink a caffeinated beverage during the day, and are more likely to have a television in the room where they sleep. So a lot of really interesting risk factors for the trends that we are seeing. But what's been most interesting, I would say, over the last 12 years or so, is looking not just at those secular trends, but evidence in the adult literature that really do correlate the increasing prevalence that we are seeing in obesity in the United States with the increasing prevalence of adults who report insufficient sleep in the United States. These are from 2 different years. I don't think we yet have an updated map for insufficient sleep among U.S. adults from BRFSS, but you could see that this almost identical, the same states where we have the highest prevalences of obesity, we also have the highest prevalences of adults who are perceiving themselves as sleeping too little. And if you look at the literature on sleep and obesity in adults, this is one of the most striking research and body of research that really started to inform some of the work that we began to do in infancy and early childhood, is that insufficient sleep duration in adults is associated with almost every single adverse health condition you can think of, all-cause mortality, lower life expectancy, cancer, obesity, diabetes, and coronary heart disease. Both, I would say, too little sleep and too much sleep in adults has been correlated with some of these chronic diseases, but very strong associations relating insufficient sleep to chronic diseases. In infants and children, a systematic review done in 2011 of 29 studies suggested that short sleep was associated with an increased risk for becoming or being overweight or obese, and also found that later bedtimes, which we know are increasing in its prevalence, is a risk factor for overweight and obesity in young children. There is some debate still, and this leads to what I'm going to mention in a bit about the research gaps in this area, about sleep and obesity in infancy, so among children under 2 years of age. There's some studies, including some of our own, that have reported an inverse association between sleep duration and adiposity in infancy, others that haven't found an association, but at least one RCT of an infant sleep intervention that did not have an effect on future overweight. Some of our own work that we've done in a large pre-birth cohort of infants and toddlers have shown a relationship between insufficient sleep in children with higher body mass index Z-score and increased odds of obesity when children were 3 to 5 years of age. And in some of the follow-up studies that we've done, looking at those same children who were reporting too little sleep in those first 2 years of life and then went on to have multiple exposures to insufficient sleep, we found that the highest prevalences of obesity, in this case reflected as a higher body mass index Z-score in mid-childhood when they were about 7 to 9 years of age, were among those children who had the most exposures to insufficient sleep across infancy and early childhood, really lending support to the fact that it might not be a critical period. It might not just be insufficient sleep in infancy, but insufficient sleep in infancy and throughout early childhood that persists to affect BMI and potentially metabolic syndrome in mid-childhood. This is from the study by Hart and al. That looked at potential mechanisms, and I should point out that almost all of the mechanisms that we know of relating sleep and obesity are in older children. So there's some really interesting studies looking at too little sleep and alterations in metabolic functioning, too little sleep and alterations in our appetite hormones. The relationship also of sleepiness and fatigue and how that affects our ability to interact or participate in physical activity. What's missing in the literature are what are the mechanisms relating too little sleep in infancy to rapid weight gain and obesity. So I'll end the discussion about sleep with quite a number of research gaps. I would say that few studies provide evidence of underlying biological mechanisms in infancy in particular, and there are quite a number of them missing. We have very little information or knowledge that's known about the interactions between sleep and feeding and introduction of inactivity in children. Most of the studies that have looked at sleep and obesity have only looked at sleep duration. And there's some really interesting findings that show that sleep duration isn't just the answer. Sleep timing, sleep consolidation, quality, regularity, and circadian alignment are just, and potentially even more so important as a risk factor for obesity. One really good example is in a study in pediatrics a few years ago that showed that African American children already by 5 years of age are sleeping almost 1 hour less than their white counterparts. And in that same study, they looked at sleep duration at night and sleep during the day and found that those children were more likely to have greater amounts of sleep duration during the day with napping and then insufficient sleep at night. And so, there's a lot still that we don't know because we've really relied on many studies, too many studies that focus only on duration, including my own. We have a number of challenges in measurement. We, right now, really don't measure sleep very well. We rely too much on parental report. And I would say, to end the discussion, that there's good evidence of the efficacy of behavioral interventions in improving features of sleep, including slim time, which you heard about earlier. But RCTs and other interventions testing whether interventions that improve sleep to affect adiposity are missing. We'll switch very quickly to physical activity and sedentary behavior. My good friend Steve Gortmaker has said a number of times to many of us that children are programmed to be like the children in this figure, to enjoy physical activity. And unfortunately, our environments and policies socialize them out of it. And it is very true. In infants, very little is known and published about the normal range of physical activity and sedentary behavior and its association with energy balance. And if sleep measurement is fraught with limitations, there are real limitations in accurate measurement of infant activity. And although some work has successfully used accelerometry, and we're getting better at being able to measure activity and sleep with actigraphs. Only one study has quantified an effect between infant screen time and childhood overweight, and it's interesting that there's so much of a robust literature among older children and adolescents relating television viewing and obesity, but there's almost no research showing television viewing in the infancy period from birth to 2 years of age relating TV exposure in that period to overweight. And this cites just one of the studies, a Generation R study of 3,600 preschool children that found no association between television viewing in infancy and childhood obesity. Again, in infants, there's also limited information and evidence about motor behaviors and physical activity promotion with obesity and adiposity. The data that we do have, one by Sarah Benjamin Nealon, looked at a study in the same study where we've looked at sleep in Project Viva, a longitudinal study in this case of 741 of those mother-infant dyads, and looked at the age of attaining certain motor milestones of rolling over, sitting up, crawling, and walking. And they found that none of those milestones were associated, or the age of attainment of those milestones were not associated with a higher body mass index Z-score, although later age at walking was associated with slightly greater adiposity when children were 8 years of age. And another study that looked at low-income African-American mother-infant dyads from 3 to 18 months of age found that delayed infant motor development was associated with greater risk of overweight and higher adiposity. No published studies, interventions have evaluated the effect of a physical activity intervention in infancy on increasing accelerometry-based physical activity or preventing obesity. So that's a little bit different from what we know of the evidence around television viewing and physical activity among children 2 to 5 years of age. And it brings up an interesting point about we wouldn't neglect 0 to 2 knowing that it's such a strong relationship from 2 to 5 on, and really brings up the issue of measurement to the forefront. Among older children, 2 and over, there's a robust and confirmed association linking television viewing and physical activity to childhood obesity with multiple longitudinal studies, multiple randomized controlled trials. In other studies that have tracked activity and sedentary behavior using electronic accelerometers, there's a consistent protective relationship of greater physical activity levels and less television viewing with decreased risk of obesity and other measures of adiposity. So children don't just wake up as 2-year-olds. There are antecedents to these behaviors that are worth paying attention to, even if we don't yet have the evidence for the relationship in infancy. So to summarize this part of the presentation, we know, and some studies strongly suggest, that insufficient sleep in infancy and in early childhood is associated with higher risk of obesity. We still need quite a bit of evidence to understand the mechanistic pathways linking the two, linking adverse sleep with weight gain, and those that extend sleep to more than just looking at duration and that use validated measures. And very similarly, there's a paucity of evidence linking physical activity or television viewing in infancy to obesity, but the robust association later in childhood means we really should be focusing on these behaviors early in life. Okay, I'll pause for a second as we head into the other discussion and talk a little bit about what I'm hoping will lead us into the moderated discussion, which is about early life origins of racial ethnic disparities in childhood obesity, where I spend actually a lot of my time these days thinking about and intervening on. So we heard from Cynthia this morning that obesity, while we've made some progress in some populations, still remains at historically high levels among children. And we know that among 2 to 5-year-old children, we have a prevalence of about 8.4%, but the highest prevalence across the board that Cynthia showed earlier is the highest prevalence of obesity is among Hispanic boys and Hispanic girls among the 2 to 5-year-olds, with almost 5 times the difference in obesity prevalence among Hispanic children compared to their white counterparts by 2 to 5 years of age. And we know that about 17.7% of all children 6 to 11 years are obese, with, again, the highest prevalences among Hispanic boys and non-Hispanic black girls. And I should say what I mentioned earlier, that those disparities, while they might not yet be present in some of our surveillance systems, possibly because of methodologic issues in those first 2 years of life, including our fraught measurements of length in the first 2 years of life, we really, again, don't wake up as 2-year-olds. And if already by 2 to 5 years of age we have Hispanic children having 5 times the prevalence of obesity as their white counterparts, it means that those disparities are emerging early in life. And so we had a number of the panelists earlier show this vicious cycle of obesity and chronic disease that we've been talking quite a bit about earlier this morning, about how pre-pregnancy overweight and obesity affects mothers' own risk for later obesity and adverse cardiometabolic health. But in Dr. Barkin's talk, we also learned that a higher pre-pregnancy BMI entering that gestational period alters potentially fetal growth and metabolism, introducing a higher risk for that infant. And so that lower cycle puts a mother's child or a mother at risk, but also her infant. And so really thinking later on in the sessions about how do we interrupt this cycle, which so many of us have talked about. But of all of the risk factors that you heard about this morning, gestational weight gain, gestational diabetes, smoking during pregnancy, accelerated infant weight gain, breastfeeding or too little breastfeeding, sleep, TV, physical activity, responsiveness, and parental feeding practices. A number of years ago, we did a study that in almost every single one of those early life risk factors, Black and Hispanic children have higher prevalences of those risky behaviors in early life. So if we're looking for reasons why a 2-year-old wakes up and has and have disparities compared to their white counterparts, we're really looking at answers in the first years of life and in pregnancy. In other work that we have done to examine whether those early life risk factors explain disparities that we see in our own cohort by 7 years of age, we have found, similar to national data, that around 7 to 9 years of age, we have in our cohort Black and Hispanic children who have much higher BMI Z-scores than children, non-Hispanic white children in this cohort. And as we adjust, and again in an epidemiologic study, this is not an intervention, but as we adjust for socioeconomic status, which we know is an important contextual influence for obesity in early life, as we adjust for parental BMI, which we heard is such an important risk factor for obesity, and as we adjust for pregnancy risk factors, infancy risk factors, and those that emerge in early childhood, we completely explain the disparities that we see in our own cohort among Hispanic, Black, and white children. This led a number of years ago to the White House Task Force report, taking some of that evidence to say and really refocusing our attention on these disparities, that racial and ethnic differences in obesity may be partly explained by differences in risk factors during the prenatal period and early life that you've heard so much about in our panel. I'll end there and take more questions during the panel. Thank you.